Hello, everyone. We are looking at the reproductive systems in chapter 26. We're going to start with the male reproductive system and then move on to the female reproductive system. So let's go ahead and get started. We're going to look first at the major male reproductive structures, and this includes the external and the internal genitalia. These are not essential to life, but reproduction is one of the characteristics of living things, and so it is part of that characteristic. And these are responsible for hormone secretion, sexual function, and gametogenesis. So this is a reminder that gametes are the sex cells. They're either going to be eggs or sperm. They're sperm in the male. The normal human body cell has 46 chromosomes, but a gamete is only going to have half of that, or 23 chromosomes. So these cells are haploid. And when you have a sperm with 23 chromosomes and an egg with 23 chromosomes, and they combine in fertilization, you're going to end up with a total of 46 chromosomes in the new embryo. Looking at some of this genitalia, we have the external genitalia of the penis, the urethra, and the scrotum. Reminder, the urethra carrying some of that urine from the bladder. And then internally, we have the testis, or the testicles. We've got the epididymis. This is part of the pathway sperm will take as they leave the body. We have several glands, so the bulbourethral gland, the prostate gland, and the seminal gland. And then we have the ductus deferens. And the ductus deferens is what's going to take the sperm from the epididymis and the testes and then help it empty into that urethra for ejaculation. So here is a little bit of that process of sperm transport. So they're going to start in the testes. Testes with ES is plural, testis with IS is singular. And then from the testis, they're going to go into the epididymis. They will travel through that ductus deferens. And then here they will enter the ejaculatory duct. And that is within the prostate. And then from the ejaculatory duct, they will go into the urethra. And you can see the urethra here where it's leaving from the urinary bladder. So the secretions, again, are from that seminal gland, the prostate, and the bulbourethral glands, and that is what's going to form the semen that carries the sperm. A couple of other things just to be aware of. You can see here where the pubic symphysis is for a little bit of location clarification. You can see the scrotum surrounding the testes. And then be aware, there's lots of jokes out there about lean over and cough to get your prostate palpated. But you can see how if you were to perform a rectal palpation, if you had a large prostate, you would be able to feel that and feel for abnormalities. We do prostate palpations in veterinary patients. And my favorite description is it was described in veterinary patients as a Barbie butt. Not the same in humans, but that's exactly what it feels like in dogs. And you're always looking to make sure that it's nice and symmetrical, not painful, not enlarged. Very important. And we'll talk about prostate cancer towards the end of the lecture today. So this pathway takes a little bit of a convoluted turn, and that's because we have the inguinal canal. And so we're going to have the testes outside of the body in that scrotum, but then the ductus deferens is going to enter into the pelvic cavity through this inguinal canal. And then they're going to go into that ejaculatory duct to go into the penis and move externally again. And these canals are these inguinal canals. They're holes that go through the different layers of fascia and tissue involving all of those abdominal muscles. So you can remember your external obliques, internal obliques, transverse, rectus abdominis, all of these layers. Through the layers, there is this little ring that opens. But this ring can lead to a weak area, and the abdominal viscera can actually poke through there. And so this is an inguinal hernia, where it can be just little pieces of fat, but depending on how big the opening is, more significant abdominal organs can become stuck there. And then if you're moving around a lot, or if a particularly large piece of tissue is stuck, that can create really significant pain and problems for the health of that tissue. So these are, there's not a full coverage right there, because we do have things going in and out. Here is that superficial inguinal ring. There is a deep inguinal ring, but we're not going to look at that where we're at right now. The testicles are covered in a muscle called the cremaster muscle, and this is what is responsible for changing how close they are to the body to help keep them at a constant temperature that's ideal for sperm production. You have the dartos muscle that is intradermal in the scrotum, and this muscle contracts and creates a little bit of that wrinkled appearance, and that's some resting tension that is in that area. And then you have the raphe of the scrotum. This is just a thickening in the area. There's a septum in the scrotum that separates the two testicles, and we have the spermatic cord. And the spermatic cord has your ductus deferens, so that's what's carrying the sperm, and then it also has a venous plexus around an artery and then nerves in that area. And this venous plexus and the artery, this is also part of maintaining the ideal temperature for sperm production, because the artery comes and is a little warmer than the ideal temperature. And so this venous blood that has become cooler since it's been out at the testicle is going to move towards the body and act as a countercurrent mechanism to cool the blood in that artery down to a more desirable temperature. So this is a small testicle. I found this picture from a dog where a cryptorchid testicle was present. So cryptorchid means hidden testicle. Orchid is the prefix for testicles. And we had to go into the abdomen of this dog to find the testicle. And how do you do that? Well, when you go into the abdomen, you actually can look for the bladder, you can look for the prostate, and then you know that that ductus deferens is going to have to somehow get to the prostate. And so you try and trace the pattern of that ductus deferens until you see the testicle. Intra-abdominal testicles or retained testicles are usually not normal in appearance, and animals have a potential to become cancerous, which is why it's important to remove them. And then you also document when it's removed, because you don't want things like that left behind, or people wondering what happened. So this was part of that documentation, but a great image of here is the testicle itself. Now it is smaller than a typical testicle. And then this is your epididymis. Usually it's a little, again, less prominent, but part of the abnormality is that it is more prominent. This is that ductus deferens, so the kind of the passageway to carry the sperm. And then here is that vascular bundle that is ligated with these hemostats. Just neat to see, I think, the anatomy in action on a specimen. So how do testes develop? They should, they appear within 2 months after conception, and they have a connective tissue band that runs all the way to the developing scrotum. And so within birth or immediately after, both testes should descend. And if one or both doesn't, then that's when in a human you would go in for surgical repair. So we can see that descent as that connective tissue band shrinks and pulls the testicle inferiorly. Spermatogenesis is the process of making sperm, and it takes about 9 weeks or so for a full sperm to be made. But this is a constant process, so it's not as though there's just a few sperm every 9 weeks. This is done through meiosis. So vocab reminder, mitosis is when regular cells divide. And so this is going to be the process where you have some gametes, some of these stem cells, they're going to undergo mitosis. One's going to stay behind to be a stem cell to make more, and then one is actually going to become the gamete. So with mitosis, you're still diploid. Mitosis, you always have 46 chromosomes. Meiosis is the process where we're going to get half that number of chromosomes, so become 23. And spermiogenesis is the process of taking immature gametes and then going ahead to have them mature into sperm. So spermiogenesis takes the gametes produced by meiosis and then is going to help them grow into mature sperm. And you can see some pictures here. These are 3D in view. Let's look at the difference in mitosis and meiosis. So mitosis is what you're familiar with from AP1. Mitosis is making a copy of a cell. And so in this case, you have 46 chromosomes. You're going to make one copy of each chromosome, and then you're going to end up with 2 daughter cells. Both still have 46 chromosomes. They're still diploid, and they are identical to the parent cell. And in this case, that cell is a stem cell. So we've divided, we've got one cell that's going to enter meiosis and become gametes, and then a second cell that's left behind to serve as the template or as the parent cell for future gametes. In meiosis, we're going from diploid, so from 46 to haploid to 23. And then we're also going to introduce some variation in the parts of the chromosomes or the particular chromosomes that are inherited. So in this case, we start with 46 chromosomes. Not only are we going to copy those chromosomes, but we're also going to pair them up. And in each cell that begins this meiosis process, there are 2 copies of the same chromosome number. So for example, you might have chromosome number 21. Everybody has 2 copies of chromosome number 21, one from their mom and one from their dad. So in this case, you've copied the chromosomes, but you've also paired it up with the other chromosome that codes for the same thing. This is known as the homologous chromosome, and that's where synapsis occurs and forms a tetrad. Tetrad because there are 4 kind of ends to it. It looks a little bit like an X. And so with meiosis 1, we are we're choosing one of each chromosome type to go to the daughters. So you can see here we've got a black and a gray of whatever chromosome number this might be. And so the chromosomes are still copied, but we're just getting one type of that chromosome. So we're only going to get the black in some cells, and we're only going to get the gray. For example, this might be the chromosome that came from the mother of this gentleman, and this might be the chromosome that comes from the father of this gentleman. And so after meiosis 1, everybody only has one copy of each chromosome, or one of each chromosomes. Now that chromosome is still doubled, and so that's where we're going to go into meiosis 2, where we're going to get rid of any doubling of the information. And so through meiosis, we go from 2N chromosome numbers from 46 to 23. We end up with 4 daughter cells instead of just 2 daughter cells in meiosis. And there's quite a bit of variation in these daughter cells, and that's part of the benefits of sexual reproduction, is the variation that we can have in gametes to produce really viable offspring. In my mind, I always remember meiosis 1. This is where we're going to split up the homologous chromosomes. We're going to go from 2N from 46 to 23. So at the end of meiosis 1, we have 23 chromosomes, but each chromosome still has an extra copy, still is doubled. And so then meiosis 2 is removing that extra doubled copy with the second division. This is also going to be occurring in female reproduction with the gametes as well, but this was a nice little spot to introduce this. So spermatogenesis is going to be, how do we get this gamete to a sperm? So the spermatogonium, that is the stem cell, and this stem cell is in the seminiferous tubules. So the spermatogonium will undergo mitosis and create a primary spermatocyte. So if I go back to this slide, this cell entering mitosis would be our primary spermatocyte. And this would be, we're still leaving behind this spermatogonium to continue the process. And your primary spermatocyte is still diploid, so still 46 chromosomes. It's going to replicate its DNA, still a primary spermatocyte. It's going to have synapsis and form the tetrads, and then it's going to become a secondary spermatocyte. So in that secondary spermatocyte, we only have the homologous chromosomes have separated into individual cells, but we're not done, because we're going to go into meiosis 2, where we have spermatids, and these are finely haploid. They have 23 chromosomes. They only have one copy of each chromosome. And then from these spermatids, we're going to go into sperm, and that's the spermiogenesis, the physical maturation. They're just not ready to go out when they're spermatids. They need a little bit of maturing time. So there's 4 phases here. These take about 64 days, but remembering they're not happening in big waves. There's just always a constant number of cells that are going through the process and maturing along the way. So where do the events take place? Well, that would be in the seminiferous tubules. So here are our seminiferous tubules. They are very convoluted, that's for sure. And each little segment of these tubules is in a different phase of the spermatogenesis. And so that's part of how we keep this constant supply of sperm. You can see here, again, all these tubules and how small and thin they are. You can see there are septa testis between them. So this is connective tissue that is between these tubule areas. Around the outside of the testis, we have the tunica albuginea, and then we have a tunica vaginalis that is more specifically around that epididymis. So the path of the sperm, they're going to go from these seminiferous tubules to the straight tubules. So here you've got the straight tubules. They will go from there to the reedy testes. And here you can see those reedy testes right here. And then they will move into the efferent ductules. So reedy testes, efferent ductules, and then into the epididymis. So here is that epididymis curled up, and then from the epididymis, that's where they're going to move through that ductus deferens. We're seeing the layers of the scrotum with the skin, the dartos muscle, and some of that superficial fascia. We have the cremaster muscle here. There is a scrotal cavity between them. And then also, again, we're pointing out the reedy testes. So you want to know the pathway to go from the seminiferous tubules, through the straight tubule, through the reedy testes, to the afferent ductule, to the epididymis, and then through that ductus deferens. Here you can see the ductus deferens peeking in the cross section. And this image is showing you the different tubules containing different developments of those spermatids. So we have a tubule here that has really early spermatids. We have a tubule here that has late spermatids, and then there is actually one containing sperm here. So each one is in a different stage of the process that's leading to a continuous production of those sperm. However, they may be physically mature when they leave the testes, but they're not functionally mature. So not, totally emotionally mature, I guess. And capacitation is the process by which the sperm becomes functionally mature so that it can swim and fertilize the egg. And that's the big thing, is its ability to gain its swimming capabilities. And so this needs both secretions from the seminal glands and then also exposure to the reproductive system. So you need to have those spermatids become sperm, and then the sperm still need to be to undergo capacitation. So let's look at some anatomy of the sperm itself. The top of the sperm, or I guess the most anterior portion, is going to be the acrosome, and that contains enzymes that are essential to fertilization. You have the head of the sperm, you have the neck, you have a middle piece, and then a tail. The head contains those 23 chromosomes, and the neck contains mitochondria. Why do you need mitochondria? Well, you've got to have some kind of energy to keep that tail moving. And so our mitochondria are there and near that flagellum tail. Sperm are missing a lot of the big organelles that we think of. And why would that be? You could take a minute to think about it. You know, at this stage, they are really just packages to get those chromosomes to the female. And so as long as they have that mitochondria and the tail, they're going to be able to get there. They're not looking to do any more division on their own. They're not looking to make any more proteins on their own. They are really just vehicles to get those chromosomes to the egg. So we've got several secretions of the male reproductive system. And so we have the seminal glands. They're also known as the seminal vesicles, and those are between the bladder and the rectum. And that makes up 60% of the semen volume. And remember, that is really important for capacitation and for the sperm to gain the ability to move. You've got the prostate gland that wraps around the urethra, so the urethra actually runs through that gland, and that makes up 20 to 30% of the semen. And you have seminal plasmin that comes from the prostate gland that is an antibiotic protein that helps prevent urinary tract infections or prevent infections that may happen around that urethra. And then you have the bulbourethral glands. These are at the base of the penis. They've also been called Cowper's glands. And these create a thick alkaline mucus that neutralizes any acids and acts as a lubricant, especially on the tip of the penis. And this is a good point for a reminder that sperm can live for several months and be stored in the ductus deferens. This is why after a vasectomy, or after even in the animal world, after you neuter your dog or cat, you don't want to immediately allow them to mate, because they may not be shooting blanks quite yet. Some of those sperm may still be alive in that ductus deferens and could still result in pregnancy. So we'll take a brief look at the anatomy of the penis. The penis is used for sexual intercourse as well as for conducting urine out of the body. Several parts. You have the root, you have the body of the penis, and then the glans penis, otherwise known as the head. Between the body and the glans, you have this area that's known as the neck of the glans. And you can see the external urethral orifice here at that glans area. The penis is full of erectile tissue, and this tissue, it is almost spongy, and it fills with blood during the erection, which creates firmness and can create swelling. There are two main parts. You've got your corpus cavernosum here, and then your corpus spongiosum. If you look at it in this view, you can see the corpus cavernosum surrounds the corpus spongiosum, which is surrounding more nearly the urethra. These fill with blood during erection, and a huge part of that is nitric oxide. Nitric oxide is a chemical that encourages vasodilation, so encourages blood vessels to get bigger. That allows things to fill with blood to create the erection. And that is one of the problems that can happen with erectile dysfunction and one of the ways that it is treated. So if you think of medications like Viagra or sildenafil, that is part of the mechanism of action that it's working on. It's working through these systems to create dilation of these vessels to support that erection. They're showing in this image a little bit the tissue layers of the penis. So you do have a dorsal vein, artery, and nerve. You've got the external skin layer. You've got a smooth muscle layer. That's a continuation of that dartos layer. And then some areolar tissue that has arteries, veins, and vessels. And then a dense network of elastic fibers to accommodate that erectile tissue. So let's talk a little bit about testosterone, because this is the big hormone that regulates sperm production. So testosterone is produced by the interstitial cells in the testes. And there's two hormones that are going to play a role both in male and female reproduction. And they're going to be released specifically from gonadotropin releasing hormone. That's going to come from the hypothalamus and then tell the anterior lobe of the pituitary gland to make luteinizing hormone and follicle stimulating hormone. These hormones have more to do with the female reproductive tract. So if you say these don't really describe what they do in the male, you would probably be correct. But it's still, we use those hormone names to describe this because they are the same, the same hormones. They were just named for their function in the female. So luteinizing hormone comes from those interstitial endocrine cells of the testes. They are going to stimulate them to release testosterone. And testosterone has effects on the central nervous system, like maintaining libido and related behaviors. It's going to stimulate bone and muscle growth. Think about several times in this class when we've talked about the male having more body fluid composition because of more muscle. That's part of testosterone. It's going to establish and maintain secondary sex characteristics and maintain those accessory glands and organs. So that's luteinizing hormone, LH. It hits those interstitial cells for testosterone. We have follicle stimulating hormone, otherwise known as FSH, that targets these specific nurse cells of the epididymis. And these cells are going to control the local environment. They're going to help with spermatogenesis and spermiogenesis. And then they make androgen binding proteins. And so these will bind testosterone or other androgens in the fluid contents of those seminiferous tubules to increase the androgen concentration within the testes. So we're going to kind of supercharge the testes with a lot of testosterone from these androgen binding proteins. And that also, they also can play a role with inhibin. So inhibin is going to come from this testosterone and nerve cell stimulation, and it provides negative feedback to say, okay, we have enough testosterone now, gonadotropin releasing hormone, hypothalamus, you can give it a break for a minute. Excessive testosterone can cause problems, especially they're seeing more now in I don't want to say middle-aged men, but men that are otherwise healthy and taking testosterone supplements for a variety of reasons, but they're seeing some more really particular types of heart disease. And there are some potential cancerous effects if you're doing this for extended periods of time. So it's not always the case like more testosterone is good. We want to have the right amount and be in homeostasis, not an excess or a deficit. So this is the end of the male reproductive system. Let's take a quick switcheroo and look at the female reproductive system. And this is from chapter 26. I'm borrowing some of Dr. Monahan's excellent PowerPoint to go over this system, make sure that we get everything that we want. So we've got some major female reproductive structures, both external and internal genitalia. This is going to produce hormones. It's going to produce gametes, similar to the male reproductive system. But we also have the ability to support and protect a developing embryo or a fetus and nourish the newborn. So external genitalia, we have internally the ovaries, the uterine tube, the uterus, and the vagina. And then the mammary glands as well are part of that female reproductive tract. And the gonads are ovaries, which are going to produce oocytes or ova. I've heard it pronounced oocytes or oocytes, but oocytes is what I've always gone with. And so ova are the eggs, another word for those eggs. So your ovaries, they are paired organs, and they have three functions. So they're going to produce immature gametes. They're going to secrete female sex hormones, such as estrogen and progesterone, and they're going to secrete inhibin because we need inhibin to shut down the process. Again, too much of these hormones is not more helpful for us. Please note there are a number of estrogens. So we refer to them as estrogens and progesterone in this presentation, but there are many different kinds and there are many different steps along the way. So if we look at this ovary, we've got the tunica albuginea. Remember, we saw that around the testis and the male reproductive tract. We have this germinal epithelium that's going to play a role in development of the egg. We have the outer cortex of the ovary and the inner medulla of the ovary. And we're seeing a lot of follicle development as well as some corpus luteums or CLs that are here as well. And we'll talk about that a little bit more. From the ovary, you've got this broad ligament and the mesovarium that are attaching the ovary in place. And then you have your uterine tube, otherwise known as the fallopian tube, which is how the eggs are going to travel from the ovary to the uterus. So here is our ovary, and then we have our uterine tube right here, so otherwise known as the fallopian tube. And then we have these fimbriae here at the end of that uterine tube. So these fimbriae are going to wave the egg in to that uterine tube through the infundibulum, and they're going to travel towards the uterus. It takes about 3 to 4 days, so it's not an immediate process. This is where the concerns for ectopic pregnancies occur, because there's not always a direct connection, and so there is the risk that potentially an egg could end up where we don't want it ideally. But the fimbriae are what's going to allow it to enter these uterine tubes. And then a couple of other things to point out here. You have this suspensory ligament. So the suspensory ligament goes between the ovary and this oviduct, or the part of the uterine tube here. You have your broad ligament. This contains a lot of blood vessels, it's supportive tissue for there. And then your ovarian ligament that's going to attach your ovary to your uterus. You have a vaginal canal here. We're seeing a little bit of that with your cervix. And then to be aware that the vaginal opening of the cervix is called the external os, and then the uterine opening of the cervix would be the internal os. And so this area and the internal os are where we're testing for with a pap smear. You have rugae in the vaginal wall, similar to the rugae in the stomach, to allow for stretch and expansion. And then just being aware that the fertilization actually takes place in the uterine tube usually. It's not in the uterus itself. And the sperm need to meet the egg about 12 to 24 hours after egg release. So there is a real issue of timing here, so that they are both meet when they are viable and in the correct place. So we have the uterus, which is a thick muscular organ sitting on top of the bladder. So let's get a little bit of perspective here. Here is our urinary bladder. Here is the uterus. We've got the uterine tube and the infundibulum, and here is the ovary. Notice that the uterus sits a little bit on top of the urinary bladder. And so if this were to become larger when there is a fetus present, that explains why pregnant women frequently have to go to urinate, because there is constant pressure on that urinary bladder and it's not able to expand as much to hold a lot of urine. There are a couple of major regions of the uterus to be aware of. So you have a fundus, a body, and a cervix. So the fundus being kind of the base of that, the uterine body, and then into the cervix. We're seeing here as well the vaginal canal. You're seeing some of those accessory glands. So remember, in fetal development, or maybe we haven't covered this, though I'm sure you will cover it as you continue your anatomy and medicine career. But males and females start with essentially similar structures in the very early stages of development. And it's the hormones, so usually testosterone and estrogen, that's going to determine the prominence of those structures, where they finally end up, what they're going to become, and what they're going to do. So indeed, females do have accessory glands. They just look different and have different functions than in the male. You have the labia at that vaginal exit, and then you have your clitoris as well. Notice your urethra, it goes anterior to that vaginal canal, which is then further again anterior to the anal opening. I think those are the big things to be aware of in this image. This is, again, these openings, this is why it's ideal for females to wipe from front to back, because you don't want to be taking bacteria and other material from the anus up towards the urethra, where you could be more likely to have urinary tract infections. And then your fundus is where, just a reminder, that's where these uterine tubes will enter. So fundus, to me, always means the depth of the pouch, or like the pouching end. So that is where these uterine tube would enter. The vagina connects the uterus to the outside world, and the sperm must pass through the vagina and then also through this external os and the internal os in the cervix to enter that uterus. So the cervix is where those cells are connected for a pap smear. And this is also what dilates during labor. If you're watching your favorite sitcom and one of the characters is in labor, you'll notice they go in and they talk about how much it measured. 10 centimeters is kind of the mark when the cervix is fully dilated and becoming ready for the baby to be delivered. One of the things to be aware of is the importance of checking for cervical cancer. It is a pretty aggressive cancer when it is not identified early. And usually that's because there's not a lot of signs of it and it grows relatively quickly. They have developed a vaccine for this. So this is the Gardasil vaccine. That is one of the recommended vaccines for children and or teens, depending on your doctor's recommendation. But 75% of cervical cancers are from HPV, or the human papillomavirus. And those are preventable with the vaccine. So this is one case where, you know, we always wish there was a vaccine that could prevent cancer, or a magic injection that could stop cancer. This is one of those. And it's recommended for not only for girls, but also for boys. They can be carriers that infect partners, and then it also can have effects for them as well if they are infected with that human papillomavirus. So it's not only a vaccine that's recommended for females. So let's look at the layers of the uterine wall. We've got the perimetrium, which is this thin outer wall here. We have the myometrium, which is this middle muscular wall, and then the endometrium is the inner lining here. We're seeing the different portions of the uterine tube. So you've got your fimbriae, which kind of wave the egg in to the infundibula. There is an ampulla. through to the isthmus, and then into the uterine part. And then here, we've been talking about this internal os, but you're able to see the internal os from this particular cavity. And then you can also see the rich blood supply that is here. Just interestingly enough, when this is in animals, it's very rare in humans where we would do an ovariohysterectomy, where the ovaries and the uterus would be removed, but it can happen. But in animals, when you have a dog that gets spayed, very frequently it is a ovariohysterectomy. And so a couple of things just to FYIs, one of the things that we're really concerned about is tying off this uterine artery and vein. That's a big source of bleeding. And so we definitely want to ligate that. Interesting enough, this ligament here and this suspensory ligament are very strong ligaments, and so they're great places to use your clamps to help visualize and see the different tissues that you're using. And then you have these uterine arteries and veins. And so that's the other big thing that we look at clamping and tying, usually anterior to the level of the cervix. But those are the two big parts that we're concerned about with having bleeding. And there is a really significant difference between the different phases of the female reproductive cycle and how much blood is going to these different tissues, what they look like, what size they are. It's really remarkable how this cycling changes what's occurring. We've got, I guess I want to clarify that the endometrium is what is built up and shed in the menstrual cycle. So endometriosis, we hear a lot about that now. That is so disorders or something that is not going right with that endometrium. So now we're going to talk a little bit about those changes in the endometrium, and this is going to cover the menstrual cycle. Be aware there are several cycles in the female reproductive tract involving the hormones, and depending on, what part of the tract they're acting on. So keep those cycles straight. Know a little bit, not only what's happening, but what hormones are contributing. So in the menstrual phase, that's where we're going to start this process. We're going to have the functional layers of the endometrium are going to be shed. So the functional layers go up to this level here, right towards this, through to this basilar artery, and this is preparing for embryo implantation. This is what is going to be shed. And this straight artery here, that is in the layer that is a source of bleeding. And so that's where that red tissue and the blood that can be seen during menstruation can come from. So here we've got our endometrium, we've got lots of glands here, we have a basal layer, but we're losing this upper, the upper layer here. That functional layer, excuse me. So then after we have shed that layer, we're going to have the proliferative phase. So we're going to have to make new cells there. So the epithelial cells are going to divide and restore the surface. The glands are going to make this glycogen-rich mucus, and we have estrogen that is contributing to that. As we move through this process, it helps me a lot to keep in mind that estrogen is the hormone that's all about ovulation, that's all about getting pregnant, making the environment nice for pregnancy, or for fertilization, shall I say, to happen. And then after that follicle has been released, the body now has said, okay, I've released the follicle, I've done all I can to prepare for fertilization, and then that's where progesterone will start to appear, and progesterone's goal is keep the body pregnant. That's that goal of progesterone, is it is the pregnancy maintaining hormone. So when we talk about the proliferation phase, we think estrogen is playing a role. It is trying to get things ready for this follicle and this egg to be released. to try and have fertilization happen. So in this proliferative phase, you can see the functional layer here. We've got a thickening of that lining. You can see uterine glands that are going to produce that mucus, and there is a restored surface through those epithelial cells. And then in the secretory phase, those uterine glands are going to enlarge even more. So we've got this giant functional layer, and we can see even in our cartoon image here how much thicker it is. And this is under the control of both progesterone and estrogen. And the proliferative cells, they come from this basal layer. So this basal layer is always going to be there. It's just, are the functional cells there or are they not? Have they been shed? That's what we're keeping track of. And I think it's good to recognize that during menstruation, it's not just straight blood that's being menstruated. Yes, there is blood involved with that straight artery, but it's also the cells of this lining and the functional layer that's being shed. So let's take a minute to look at some of these other phases. So let's focus right here on the endometrial changes, because this is just what we looked at. And I think it's helpful to remember that everything is divided into this follicular phase of the ovarian cycle, where we're developing a follicle to make an egg. And then kind of the dividing line is ovulation. We've released the egg, and then we enter the luteal phase. And the luteal phase is named for this corpus luteum. Corpus luteum means white body. And so after ovulation, the follicle actually, it literally looks this like white coloration, and this is what is producing the progesterone. So here you can see as that corpus luteum forms and matures, we're getting lots and lots of progesterone here. And if we remember from the slide we were just at, progesterone and estrogen is going to make a lot of secretion by those uterine glands in this secretory phase. So progesterone, secretory phase, corpus luteum here. And that's all part of our luteal phase. The other phase is the follicular phase. And so this is driven by estrogens. The menstrual phase is part of that follicular phase. So we're saying, okay, we don't need to maintain a pregnancy anymore in the body. Let's go ahead and reset, repair, and regenerate a nice new fresh functional layer to be ready for our follicle when it ovulates. So I think that is really helpful to keep in mind in this process. Remember, we have our gonadotropin releasing hormone from the hypothalamus, and we're going to be making follicle stimulating hormone and luteinizing hormone. So in the males, the hypothalamus is releasing those gonadotropic releasing hormones steadily all the time, versus in the females, they come at different frequencies. And those frequencies are going to give us these peaks that we see in FSH and LH. So here is that GnRH that's coming from the hypothalamus, that gonadotropin releasing hormone, and it's coming at pulses, and they're going to come more and more frequent as we reach this ovulation phase. And then as they're more and more frequent, they're going to say, okay, body, let's make some LH and let's make some FSH. FSH is follicle stimulating hormone, and so it is stimulating the follicles. So it is elevated and a little bit stable, giving time for those follicles to stimulate, and then at ovulation it spikes and kind of gives them one last push for development. And that luteal hormone or luteinizing hormone is going to spike, and that is what induces ovulation itself and leads to that corpus luteum. So estrogen itself, well, we talked about our gonadotropic releasing hormones. So let's look down here and see what hormones are coming from the ovaries. So in the ovaries, the estrogens are slowly rising for about 7 days. And then as the follicle grows, they're going to be released really rapidly because the follicle is more developed. The follicle is able to release that estrogen. And there's inhibin that's also being released from those follicles. And the goal of inhibin is to prevent that LH release. So, it's like, okay, hold off. Don't release the LH. Don't ovulate yet. We've got to get some more development. Don't ovulate yet. But eventually it is overcome. So we've overcome that inhibin, and ovulation occurs, and then that corpus luteum is able to produce progesterone. This lower graph is looking at basal body temperature. And this is one of the ways that ovulation can be tracked in females, and this is in humans as well as other animals, because there is a drop in body temperature before the LH surge. And so that can give a marker of when ovulation occurred, which would show a time when an individual is especially fertile or especially likely to become pregnant. So couple of reminders, I guess. The menstrual phase is when those follicles start to develop. So remember, the body has said, there's no fetus to maintain. Let's go ahead and get ready for new ovulation. So they're going to clean everything out and then put down a new phase, all with the help of estrogen. The egg is released at the secretory phase because we've got to have a nice wall that's going to support its implantation. So things like that can kind of help me remember where we are at the different steps. The tertiary follicle, and we're going to talk a little bit more about the different follicles, but that is what releases the egg and then what the corpus luteum forms from. And if there's not any fertilization, then that corpus luteum is going to become a corpus albicans. And then it will just go ahead and we'll go back into the cycle, into the follicular phase, versus if there is fertilization, that corpus luteum is what's going to be present and what's going to maintain the pregnancy. So keep in mind, just this chart can seem overwhelming, and it may be helpful to print it out and to either write down what each little segment is telling us. But no, we're looking at follicular phases. When's the follicle growing? What's causing ovulation to occur? And what's the luteal phase going? And we're seeing what are the hormones that are coming from the hypothalamus and from the pituitary. So our gonadotropin releasing hormone, our FSH, and our LH. And then we're seeing what are the hormones coming from the ovaries doing. And those are partially being triggered by your FSH and LH causing these follicles or these corpus luteums develop. And then these structures release these ovarian hormones. We're seeing what the uterine wall looks like, and then as well what the change in body temperature can do as if we're tracking the cycle. So take some time with those images, take some time with the hormones, try and see if you can get that picture straight in your mind. So we've got our mammary glands, and this is moving ahead, I guess, in the process. Now we've had the baby, and this is what's used for lactation. So breast milk is the best nourishment for infants. It helps brain development because it really is high in fat. There have been some studies that have shown it reduces the risks of asthma and allergies, along with vaginal birth. Those can be factors that can help limit that. And it has lots of immune benefits for the baby, and that can reduce inflammation in general. It does require a significant caloric investment. I will never forget my first friend out of college had her baby, and being young, she was always worried, what am I going to bounce back from pregnancy? And she in particular lost a lot of weight just from making milk to supply to the baby. It's not that way for every woman, but I always think of her to remember how calorie intensive it is. And then there's different densities of breast tissue, and there are some breast tissues that are especially dense that don't X-ray well for tumor detection with the mammograms. And so be aware and talk with a physician about what's going to be the best method for tumor detection. Sometimes they'll do one mammogram and then say, yes, this is not a great candidate for this method of detection. Let's use a different method of detection. It's good to recognize that the size of the breast is not related to the amount of mammary glands there or the effectiveness of the mammary glands. It is more a relation as to how much adipose tissue is in the breast, and that is more likely to be genetic. So if you look here, you can see all of that adipose tissue. You can see some suspensory ligaments that are trying to support that because that tissue is heavy. You can see the secretory alveoli and the lobules. You can see that they drain into a duct and then a sinus where they can come out of that nipple. And you'll notice that there are multiple little ducts that will come out of that area to transfer the milk. So we've looked a little bit about the cycles. Let's look at how we produce an oocyte, and that is through oogenesis. So unlike males, females produce their primary oocytes from the stem cells, the oogonia, and this is during fetal development through mitosis. So, once they undergo fetal development, they're not making new primary oocytes. You're born with the eggs that you have. It doesn't continue. So late fetal development, these primary oocytes are undergo meiosis, but they're going to pause in meiosis 1, and they're going to remain suspended until puberty. And then when puberty comes and we start having those hormones released, your FSH is going to trigger that ovarian cycle, and specifically start the follicle formulation. And so each month, a couple of primary oocytes are going to complete meiosis 1 and mature. And the first oocyte that matures will ovulate, and after it ovulates, it's actually going to enter meiosis 2 and pause in metaphase. And then when fertilization occurs, meiosis 2 is going to be completed. And so your tertiary ovarian follicle is this follicle that's kind of paused in paused at the end of meiosis 1 and then is going to enter meiosis 2. In oocytes and in gametes for the female, not the sperm, the divisions are all unequal. So oogenesis is going to only make one viable oocyte versus in sperm, each stem cell can make 4 viable sperm. Why is that? Well, in the case of egg formation or ova formation, each division is unequal. So you may divide and end up with 4 nuclei, but every time the division happens, the cell that is going to become the egg is going to receive all of the cytoplasm and most of the organelles. And so the other 3 structures, they're known as polar bodies. They're just little nuclei with not enough left. They're not really going to have what's needed to be fertilized and become an embryo. So let's look a little bit at this follicular process. So here we have primordial ovarian follicles in the egg nest. We've got a primary oocyte here. So remember, this came during fetal development. And then we're going to have the formation of a primary ovarian follicle. So a couple of things to recognize on this chart. This chart makes it look like the little follicles move around the ovary on a conveyor belt. That is not true. They stay in one place and undergo each of these phases. This is just for documentation purposes to show. But, if this follicle was developing, it would end up with its follicular fluid. It would end up ovulating, and then the corpus luteum would be right here. So keep that in mind. So our primary ovarian follicle has these granulosa cells around the outside. You've got some fecal endocrine cells, and then here is that primary oocyte. Remember that in this phase where follicles are growing, we're under the influence of follicle stimulating hormone, and these are producing estrogen and inhibin. So again, keep that in mind. Well, we got our secondary ovarian follicle. We're going to pick up this zona pellucida. It means clear zone around our oocyte. We still have these granulosa cells and these thecal cells. And then we're going to go into this tertiary ovarian follicle. And this is what is going to get ready to be released. So we've not completed meiosis 2. We've been paused in that process. Here we have the antrum that has follicular fluid. We've got our secondary oocyte. We've got this corona radiata. And then we're going to have the secondary oocyte that ovulates. And then from that ovulated, so secondary oocyte is what ovulates. There's our ruptured follicle. From the ovulation, we're going to have the corpus luteum. There it's going to secrete the progesterone to maintain that lining. And then if there's no fertilization, the progesterone and estrogen levels will fall, and the ovarian cycle will begin again, and the uterine lining will be shed. Couple of well, let me back up one more thing before I do this. There's usually only one follicle that is in this tertiary follicle stage. Now, granted, some women will have multiple follicles that will ovulate, producing fraternal twins. But usually there's only one. And so it's that one follicle that's going to be there when that LH spike happens to cause ovulation. Couple of well, no, I'm not ready for that yet. I was going to give you some fun veterinary clinical correlations because this stuff in animals is very interesting and applicable, but let me show you one more hormone chart before we start. This chart, you have already learned everything on the chart. It is just showing you in another phase. So if you'll look down here, you'll notice that we've got stimulation and inhibition. So helpful to know. Let's just talk through it one more time. So from the hypothalamus, we're going to have that gonadotropin releasing hormone. In males, it's a little more stable. In females, it does change depending on the cycle. And that gonadotropin releasing hormone goes to the anterior lobe of the pituitary to make to produce and secrete FSH and to produce LH. So FSH happens in the follicular phase of the ovarian cycle. It's going to stimulate the follicle development. It's going to cause inhibin to be secreted, and that follicle is going to lead to estrogen secretion. And that estrogen is going to go throughout the whole body and have functions on the central nervous system, on muscle and bone growth, for secondary sex characteristics, for the accessory glands and organs. Some of that should look similar to what we saw testosterone do in the male, except in the female, this is going to have different effects. But that estrogen as well is going to stimulate the endometrial growth and secretion. So before day 10, this inhibin is going to stop any secretion of LH. But after day 10, as that estrogen level increases, then it's going to overcome the inhibin, and we're going to have secretion of LH. And secretion of LH is going to finish meiosis 1. It's going to lead to ovulation, and the corpus luteum is going to form. And so that luteinizing hormone is what begins the luteal phase of the ovarian cycle. That corpus luteum is going to make progesterone, which again is going to sustain that endometrial growth and secretion. And then that progesterone, again, is that negative feedback to go back to the hypothalamus and say, hey, don't produce any more gonadotropin releasing hormone for now. So we've got a couple of places where there is that negative feedback. So I think it's helpful for me to always remember follicle stimulating hormones, making the follicles happen, so that the ovulation can occur. After ovulation, your corpus luteum is keeping that luteal hormone or luteinizing hormone luteinizing hormone causes that corpus luteum to be formed, and then that corpus luteum is using the progesterone to hold on to that pregnancy. So two really fascinating, hopefully clinical correlations that will make it make sense. One is the false pregnancy of the dog. In animals, in dogs in particular, once they ovulate, that corpus luteum it doesn't always regress and will hang around. And it kind of just hangs around for the amount of time a dog would be pregnant. So like that 56 to 65 day range. And so it is not uncommon for dogs to come in when they're intact with a false pregnancy. And they come in, the report is that they're releasing milk from their mammary glands, and then also they're starting to show this like nesting behavior. Some of them will take on like little stuffed animal toys because after they ovulated, that corpus luteum was present, and that corpus luteum is just going to hang out the full gestational period. And so the dog's body thinks that it is pregnant. It is not pregnant. There is no fetus there, but everything else that comes with the progesterone and comes with late stage pregnancy is happening. And so the treatment is you really have to ride out that corpus luteum. And the biggest directions, this was my one moment, I would always say, please do not milk your dog. Because the more you stimulate by milking, the more milk they're going to produce. And so they have little tight suits that you wear to kind of put some pressure, gentle pressure on those mammary glands to reduce milk production. This does become a problem in older female dogs because sometimes there will be infection in that uterus. And when that corpus luteum appears and produces the progesterone to maintain what it may or may not be a pregnancy, it actually just closes things up and maintains the infection. And so this is what's called a pyometra, when the uterus has filled up with pus. And that's another diagnostic criteria we used for that, was to say, okay, when was her last heat cycle? When we knew the last heat cycle had happened in animals, that's related with ovulation. And so we could tell when she ovulated, about how long it had been since ovulation, and that would let us know there would likely be a corpus luteum present here that could be maintaining this infection in the uterus. And in those cases, you do have to go in surgically to remove the infected uterus. It's a pretty big emergency. The other thing that is super cool about all of these hormonal things in animals, it has to do with milk. So to have milk in cows, they have to be pregnant. And so a huge part of the dairy industry is making sure that we know when cows are maximally fertile, what stage of the cycle they're at, and are they cycling normally. And part of that process is to say, you know, do you have a corpus luteum and you're not pregnant? How can we get this cow cycling again? Or you know, are the follicles developing like they should? Because we want the cow to ovulate, we want her to get pregnant, so that after she has the calf, we're able to collect that milk. And so I think we talked before about in horses how when you reach in rectally, you can feel that intestinal tract, but you can also feel the ovaries. And a big part of the dairy industry is ultrasounding rectally to see what is happening on the ovaries and is there a fetus present. And you don't, some people can actually feel that. So you can feel a really large follicle. You can sometimes feel a corpus luteum and they will feel different on the ovaries. But they do make ultrasounds that are designed for that. And in school, I spent some time up in New York and Pennsylvania, and I will never forget that there were some Amish farms there, and I was being shocked that they would use the ultrasound for that. Well, they weren't the ones using it. So in that particular community, the vets would come in and use the ultrasound. They had the lanterns with fire there. There was no other technology, but we were able to go in and look, and you could say, yes, this cow is pregnant, you know, go ahead, get her on some food to support her so that she can carry a calf. Or, you know, I saw this cow a week ago and she had a really nice follicle. That follicle is gone and she's got a corpus luteum, but there's no signs of an embryo there. So let's go ahead and see if we can get her cycling again, because she wasn't impregnated in this life cycle. And the follicles literally look like black fluid-filled structures. You look at it and you measure how big they are. And then the corpus luteum literally look like white kind of solid structures when you're looking with the ultrasound. So that's also in humans. What part of the process of infertility treatments or in vitro fertilization or any kind of drug-assisted fertility is ultrasounding the ovaries. Fortunately, it does not always have to be transrectal in humans, thankfully. Seeing what size is the follicle, where are the corpus luteums, how can we provide hormones that are going to help it develop and have its best chance of ovulating well, being fertilized, and maintaining that pregnancy. So neat, hopefully to you, clinical correlations. Let's talk a little bit about birth control. These options don't do so much for sexually transmitted infections. So, you know, for sexually transmitted infection control, you want to stick with condoms or stick with abstinence, because that's the way you're going to prevent those infections. Condoms are available over the counter. They do offer good birth control when used correctly. There is hormonal birth control, and this is through a prescription, though there is some progesterone hormonal birth control that's available over the counter now. And these will prevent conception. There are oral pill forms, there are injection forms, and there are implants, like little beads that have the hormone that can be implanted or injected into the area. And these are going to maintain the secretory phase of the uterine cycle. It's going to maintain the corpus luteum so you don't have ovulation. The progesterone-based hormonal birth control has little known risk, though the estrogen is still prescription, because in older females and females that are smoking, there's an increased risk of stroke and heart attack. It's not a reason they can't be used, but it is something to discuss with a physician. We have intrauterine devices. These require medical professionals, and these are actually implanted within the uterus. They can be copper in nature, where the copper mechanically prevents fertilization and implantation, or they can be hormonal. These can be uncomfortable to have placed. And so an emerging field is pain control for this procedure, because it can be uncomfortable for even a couple of days after. So if it is the sort of situation where you are getting an intrauterine device, or a patient that you have is getting an intrauterine device, please make sure to ask about pain control and how pain's going to be managed. There are good options. It's not just a situation of, well, suck it up and bear it. There is pain control, and every woman deserves that. For sterilization, so in males, we can have a vasectomy. So we're going to cut that ductus deferens so that there's no sperm that are getting there to be ejaculated in the semen. This is more easily reversible, so it can be reversed, versus a tubal ligation in females. You're actually removing and that ability for that uterine tube to carry an egg, and that can't be reversed. So that is a more permanent way to prevent pregnancy. Plan B, or the is over the counter. It's also sometimes called the morning after pill. This medication, usually given within 72 hours after intercourse, will either prevent ovulation, it may delay ovulation, or alter ovulation, and then it can also interfere with the fertilization process. So there, depending on what part of the cycle the female is in, that's going to affect a little bit what part of the cycle this can work on, but it really affects ovulation and prevents that fertilization. And then you've got the rhythm method. This has a really high failure rate, up to 20%. This is the method usually where people will track their cycle. So either tracking temperature, tracking the vaginal secretions, tracking hormonal changes, and try to only have sex the times when fertility is less, but that's a pretty high failure rate for 20%. So if you are not interested in becoming pregnant, that is not a great birth control method to use because of the high failure rate. Also, don't forget that with methods like the pull-out method, or even with the rhythm method as well, there are sperm that are on the external genitalia, even released in some of the pre-lubricating fluid that comes from the male, that can find their way to an egg. So some people talk about, like, oh, the pull-out method, then no sperm are going to get to that egg. Unfortunately, there were sperm on there to begin with, and so there's still a chance of pregnancy. So some additional clinical correlations. We've got prostate cancer. It is the most common male cancer, and it is tested for with a PSA test. That's prostate-specific antigen test. If it's diagnosed, it can be treated with radiation and surgery, and it does not have a terrible prognosis. I will raise up on your radar that there is lots of conversation right now regarding PSA screenings. There is always a risk benefit to screenings, and the fact is screenings catch disease early when they're most treatable. But the more screenings that you do, and depending on how specific your screenings are for disease, there is the chance that you will get a lot of false positives. So the test will show up as being cancerous, but it actually won't be cancerous. And in those cases, when you have a lot of those, you're putting people through a lot of invasive procedures, whether that's surgery or radiation, or even just more tests like biopsy, that they may not need to go through. And there comes a point in testing when the testing becomes more damaging to more people by doing all of these extra biopsies, the extra procedures, the extra side effects and complications that can come from that, than the benefit. And how do you reduce that? Part of that is selecting who you test more carefully. So don't just test anybody willy-nilly. Have certain criteria that make it more likely for the disease to be really cancerous, so that the testing is more likely to be accurate. There's a whole statistical process involved in that, but I mostly bring it about to say that you may be hearing in the coming years that there are different criteria on when the PSA should be performed. And so don't be surprised if you hear that. There's also some rumblings about this as far as mammograms go as well. So how do we screen for breast cancer without getting a lot of false positives that cause invasive things like biopsy, but without missing any? Testicular cancer usually occurs not because of the cells of the testicle itself, but from abnormal spermatogonia or spermatocytes. Sometimes these can be hormone producing. If these are caught early, then oftentimes the testicle can be removed and have a fairly good prognosis. Breast cancer, you can see here an example of a breast cancer with calcification. It is one of the most common cancers for females, and there is a wide variety of them with a variety of treatments. You can even have breast cysts that are masses that are an inflamed lobule that has gotten walled off by scar tissue. So it's your reminder that, as my nurse practitioner tells me, on your 40th birthday, you get to go get your mammogram. It's a great gift for yourself and for those you love. Ovarian cancer is known as the silent killer because it doesn't give a lot of signs, and usually by the time that it is diagnosed, it has already spread significantly. These are also more likely to be carcinomas that are aggressive, and you can really only get remission in 1/3 of patients. We talked about cervical cancer briefly, the fact that the human papillomavirus, or HPV, causes about 75% of these cancers, and the importance of the pap smear to be screened early while they can be treated before they grow. And then sexually transmitted diseases include things like chlamydia, HIV, syphilis, or gonorrhea. Again, prevention for those is usually going to be through using a condom or abstinence, though I know there are drugs in the work that are trying to reduce the spread of those in other ways. They're still early in the process. Recognize that these sexually transmitted diseases do have the potential to lead to sterility, so they're not just annoying in some ways. They can really cause big systemic issues. And then I did want to mention one thing that's not on here just to put on your radar, and that is benign prostatic hypertrophy or hyperplasia. It's also known as BPH, and this occurs as we have less testosterone from our interstitial cells. And in these cases, the prostate becomes enlarged. It can cause some pressure on the urinary bladder, and then it can also constrict the urethra. And this is experienced by a large number of senior men, where there is either difficulty voiding or a sense that you can't void. And so there are medications that are used to treat this as well. It's just something that you will see very commonly in clinical practice. You may not be the one managing it, but you may see those medications. Flomax is one of those that these gentlemen are on. So this is the end of chapter 26 on the reproductive system, and good luck as you study. Feel free to email with any questions. Have a nice day. Bye-bye.